نبلش بالهايبرتنشن. خدته في normal physiology انه what determines the blood pressure is the cardiac output والperipheral resistance. اوكي، وفي اللي بيتحكم بهاي الاشياء مثلا diameter of arterioles والفلو. اوكي، كل هاي بيحدد البلد بريشر. اوكي، اللي بينظم البلد بريشر neurohormonal responses. Okay, to keep the blood pressure in the normal range. Okay. Part of these neurohormonal response affects the cardiac output. Others affect the total peripheral resistance. Okay. And the aim of these neurohormonal responses is to keep it in the normal range. Okay. If it's high, then the neurohormonal response works to lower it, and if it's low, it works on bringing it up to the normal range as much as possible. Okay. So definition of hypertension, we have to remember it's persistently elevated blood pressure. Okay, persistently elevated, not just one reading. Okay, so it has to be persistently elevated. If it's checked multiple times and it's high, or if you're using an ambulatory self-recorded blood pressure measure and all the readings are high, then this is by definition hypertension, not one reading only. Okay. Okay, this is the old classification, JNC7 classification. This is what they used to classify blood pressure stages. Okay. Now we use, because of this study, the sprint trial. Okay. They changed the classification of blood pressure stages. Okay. Because in this study they showed that intensive treatment with a systolic of blood pressure of 120 compared to systolic blood pressure of only less than 140, they showed that the primary outcome was less than the intensive group. Okay, and the primary outcome was the following. Okay, myocardial infarction, acute coronary syndrome, strokes, heart failure. Okay. These were the primary outcome in this study, and it was less than those with intensive treatment. Okay, it also showed that the death rate was lower in the intensive treatment group. Okay, those with systolic blood pressure less than 120, the death rate was lower than those with systolic blood pressure less than 140 only. Okay, so because of this, they changed the classification of stages of blood pressure stages according to this new staging, American College of Cardiology and American Heart Association. Okay, and the next table, and this puts them together, the old classification and the new classification. So the major difference is we no longer have this category as pre-hypertension. Okay, this pre-hypertension range in the new classification now is stage 1. Okay, so you have more patients diagnosed with hypertension. Okay, and we don't use the old term pre-hypertension. We use the term elevated blood pressure. So this category, this range is no longer called pre-hypertension. It's stage 1. Okay, the one near the green arrow. And we don't use pre-hypertension, we use elevated blood pressure. And because of this, the percentage of US adults with hypertension went up from 32% to 46% because of the new classification. Okay. Some definitions of terms that we use in hypertensive diseases. Okay, white coat hypertension. This is somebody whose blood pressure is normal at home and high at the clinic. Okay, in a clinic setting or when it's checked by a nurse or a doctor, they have high blood pressure. We call it white coat hypertension. It's not completely normal. Okay, 20% of these patients will end up with hypertension in the future, and they have increased risk of development of persistent hypertension. Okay, masked hypertension is the opposite of white coat hypertension. These are hypertensive patients at home, but the blood pressure is normal at the clinic. Okay, but it's not normal. Okay, they have increased cardiovascular mortality. Okay, as those with persistent hypertension. Okay, the only way to find out a way to to diagnose these patients is the ambulatory blood pressure monitoring. Okay, it checks blood pressure automatically at home, during the day, night, sleep, any setting. Okay, and based on the readings, you can diagnose these hypertensive types. Okay, pseudohypertension. This is pseudohypertension means the blood vessels are, the walls of the blood vessels are stiff. So the classical way of checking the blood pressure in these patients won't be accurate in measuring the blood pressure. Okay, so if you place an intra-arterial line, a sensor inside the artery, the blood pressure will be normal. So these pseudohypertension, they don't have hypertension. It's just the stiff blood vessels don't collapse when you inflate the cuff. Okay, but when you put an intra-arterial line inside the blood vessel, the lumen, this way you don't need to collapse the blood vessel. It checks the blood pressure directly from inside the artery, and it's going to be normal. Isolated systolic hypertension, that means only the systolic component of the blood pressure is high and the diastolic is normal. Okay, and usually we see it those with stiff aorta. Okay, the large vessels. Okay, you can see this in those with stiff large vessels. Okay, resistant hypertension are hypertensive patients who do not respond to 3 medications. One of them is a diuretic, and all 3 medications are given at the highest dose. Okay, not just a small dose. So 3 medications, optimal dose. One of them is a diuretic, and you cannot control the hypertension. We call it resistant hypertension, and this is one of the signs of secondary hypertension, not responding to treatment. We think of secondary causes. Okay, diurnal variation of blood pressure. So normally, when you sleep, your blood pressure dips like 20%. It goes down about 20% while you're asleep. Okay, if your blood pressure during the day or while you're awake is normal, but when you sleep, you don't have this this dip. Okay, so these dippers. Okay, these are normal people. Okay, this is normal. If you don't have this dip, okay, so non-dipper or reverse dipper, even if your blood pressure during the day is normal, this is not normal. Okay, you still have increased risk of hypertension problems, and it's another sign of secondary hypertension. Okay, so normally you should your blood pressure should go down by 20% while you sleep. Okay, you're a dipper normally. Non-dippers or reverse dippers, okay, they are increased risk of left ventricular hypertrophy, okay? And it suggests secondary hypertension. Okay, maybe you took in the skills lab how to measure the blood pressure using the stethoscope. Okay, so the patient should be resting, sitting, back supported, feet on the floor. Patient shouldn't be upset. Not drinking coffee, smoking, hot showers. Okay, bladder should be empty. Okay, you should check like 2 or 3 measurements and take the average. Okay, so or you can use a machine, validated machines. Okay, so validated machines are probably better than checking the blood pressure the manual way. Okay, as long as the machine is validated and gives accurate readings. Okay, another way of checking blood pressure, the ambulatory monitoring. Ambulatory monitoring, that means a device is attached to the arm of the patient, and it takes blood pressure like every 15 minutes for several days. Okay, and it helps us to diagnose white coat syndrome, masked hypertension, and also to check for diurnal variations like dippers and non-dippers. Okay, because it checks blood pressure while the patient is sleeping also. Primary hypertension, we use this term primary hypertension if we can find a cause for the high blood pressure. Nothing to suggest a secondary cause. Okay, its prevalence varies from country to country. Okay, but it's very high in general in all the countries. Okay, it requires a lot of medications and investigations. So it costs. Hypertension is a burden on the health system, but it needs to be treated. Okay. Some risk factors for primary hypertension: family history. Okay, it can run in families. Congenital factors like low birth weight. Okay, because low birth weight babies have less nephrons and are at an increased risk of developing hypertension in adulthood. Okay, diet and toxins, high sodium, low potassium diets increase the risk of hypertension. Some toxins like heavy metals, lead, cadmium. Okay, alcohol consumption. Okay, all are factors that can raise the blood pressure. Metabolic factors: high uric acid, insulin resistance. Okay, elevated hematocrit. Socioeconomic status. Okay, poor socioeconomic status is associated with high blood pressure. Okay. This curve shows the pressure natriuresis relationship. So the green curve is the normal curve. Okay, so if you have excess sodium, your body will increase the natriuresis, elimination of sodium, without raising the blood pressure. Okay. In some people, in some hypertensive patients, not all of them, if the patient has excess sodium, the body increases the blood pressure to increase the sodium elimination. Okay, so that's why sodium restriction helps these patients to control their blood pressure. Okay, because if they have excess sodium, the body will increase the blood pressure to increase or enhance the sodium elimination. Okay, but this does not exist in all hypertensive patients. In some of them. Okay. Etiology and pathogenesis. Okay, there are some genes that were discovered that associated with hypertension, like 20 genes. They all have to do with sodium handling in the distal tubule and collecting duct. Okay, but not all patients have these mutations or abnormal genes. Okay, low nephron number, as we said, in those with low birth weight. Okay. Complications of hypertension. Why is it important to control the blood pressure? To avoid these complications and consequences. Okay. So on the heart, it causes initially left ventricular hypertrophy. There will be hypertrophy, diastolic dysfunction, and later on, there will be dilatation in the chambers, the left chamber, left ventricle, and cause congestive heart failure. Okay. Hypertension also causes atherosclerotic coronary artery disease. Okay. And not just only the coronary arteries, okay, other vessels like carotids, renals, okay, lower limbs, okay, all can become atherosclerotic and cause ischemia, and in the heart can cause coronary artery disease. Okay? Dilated hearts also at higher risk of developing arrhythmias. Okay, the echocardiogram here shows on the top the mass of the left ventricle, which is enlarged. Okay, this is left ventricular hypertrophy. Okay, it's very muscular. Okay, this is because of the high resistance. The heart is pumping blood against high resistance. Okay, also hypertension increases the risk of stroke, okay, ischemic and hemorrhagic, and those with high blood pressure also have impaired cognition compared to normotensive patients. Okay, if you do cognitive functions on them, if they had high blood pressure for a long time, undiagnosed or untreated or not controlled, after many years, their cognitive functions are lower than normotensive patients. On the kidney, high blood pressure causes arteriolosclerosis, okay, and chronic kidney disease eventually, okay. So it can cause chronic kidney disease and even end-stage renal disease if it's not diagnosed or controlled. Okay, on the retina, it can cause retinopathy, okay, ranging from hemorrhages, exudates, cotton wool spots, which are small strokes, micro strokes in the retina, okay, and can cause blindness if not treated early on. So how do we treat hypertension? We have non-pharmacological treatment or prevention, and pharmacological treatment, okay. Non-pharmacological, which is for every hypertensive patients. It's even healthy for non-hypertensive people, okay, but for every hypertensive patient, weight reduction, okay, this can help lower the blood pressure. A healthy diet, high in vegetables, less carbohydrates, can lower the blood pressure. Low sodium intake, okay. Physical activity, even if you don't lose weight, physical activity can lower the blood pressure, okay, even without losing weight, okay. So, but physical activity with weight reduction, both of them can help us lower the blood pressure. If the patient is on medications, they might take less medications or a lower dose, or even take them off the hypertensive medications if they exercise and lose weight, okay. Okay, also alcohol and consumption, if you lower it, also will control the weight. So what do we use for blood pressure treatment if we are going to use pharmacological treatment besides the non-pharmacological approach? These are the first line medications: thiazides and thiazide-like diuretics, ACE inhibitors, ARBs, and calcium channel blockers. So you should start with these medications unless there's a good reason to use one of the secondary agents like tube diuretics, potassium-sparing diuretics, aldosterone antagonists, beta blockers, alpha-1 blockers. So these other medications are second-line agents, okay? You might use it, you might start with one of them if there's a good, like beta blockers in somebody with coronary artery disease. Okay, coronary artery disease, they are usually placed on beta blockers. So it works both ways for coronary artery disease and for blood pressure. Alpha-1 blocker for those with benign prostatic hypertrophy. Okay, you can use it. It works for benign prostatic hypertrophy and hypertension. But you have to have a good reason to use the secondary agents. Loop diuretics, those with chronic kidney disease stage 4, they don't respond to thiazide diuretics, so you can put them on loop diuretics. Okay. So if you have a good justification to use one of these secondary agents initially, then you can use it. Otherwise, you should use the primary agents, and then if you need to add one of these secondary agents, that's okay. In the past, the elderly patients. So in this table, I'm going to focus on the old people, or more than 65 years old. They used to let them run high, okay, like even if the blood pressure is systolic between 140, 150, they used to let them, stay at that level, high level, okay. But they found out that if you lower the blood pressure to normal, like the normal adult, the young hypertensive patients, there's an increased benefit in elderly. But you have to be careful, okay, make sure it's appropriate with that elderly patient. Like hypertension increases the risk of falling down. So not every elderly patient might benefit, but according to studies, elderly patients also benefit from controlling the blood pressure to the normal range, not keep them on the high level, okay? So this algorithm shows you how to approach anybody for blood pressure from normal to stage 2 hypertension. And normally, they should check the blood pressure at least once a year, okay? Plus healthy lifestyle, okay? Other elevated blood pressure, they should start with non-pharmacological therapy, okay? And check their blood pressure over 3-6 months. Okay, stage 1, okay? Definitely non-pharmacological therapy plus medications depending on their cardiovascular risk, okay? If it's their cardiovascular risk more than 10% or equal to 10%, or if they are diabetic, okay? You should also start pharmacological therapy, okay? And you you should check them more frequently, okay? And stage 2, definitely you should start blood pressure lowering medications with non-pharmacological therapy. So non-pharmacological therapy is for everyone, okay? And when to start the blood pressure medication depends on the stage and risk factors mainly. Okay. So this table shows other comorbidities like coronary artery disease, myocardial infarction, and the appropriate blood pressure medications to select for them, okay? So if they have a comorbidity, you should choose a blood pressure medication that works for both the comorbidity and hypertension, okay? As we mentioned, coronary artery disease, they benefit from beta blockers, okay? Okay, they also benefit from RAS blockade, ACE inhibitors and ARBs. Heart failure, they benefit from ACE inhibitors or ARBs or RAS blockade, okay? And they might need also diuretics. The heart failure patients might need loop diuretics, okay? So depending on the comorbidity, diabetics with diabetic nephropathy, definitely RAS ACE inhibitor ARBs lowers the mortality, cardiovascular risk, and also protects the kidneys. It slows the progression of chronic kidney disease. Okay. Now we'll talk about hypertensive urgencies and emergencies. Okay. So emergency compared to urgency. Emergency, there is end organ damage. Okay. They have very high blood pressure, more than 180 over 120, with end organ damage like coronary ischemia, aortic dissection, pulmonary edema, encephalopathy, retinopathy, nephropathy. So very high blood pressure with end organ damage, we call it hypertensive emergency, okay? Notice. So in this case, we need to lower the blood pressure like within few hours. So we lower the mean arterial pressure by 20 to 25% within 1 to 2 hours, okay? And in this case, we need intravenous medications. Okay, you have intravenous sodium nitroprusside, nicardipine, nitroglycerine, hydrazine, enalaprelate, which is an IV ACE inhibitor, esmolol, an IV beta blocker. So in these patients, they have end organ damage, and you need to lower the blood pressure within a few hours, and you need IV medications initially. Okay, because you have end organ damage. Okay, in hypertensive urgency, you have very high blood pressure, but there isn't end organ damage. There's no end organ damage. Okay, in this case, you don't need to lower the blood pressure within a few hours. You can leave it like you can lower it over a day or two. Okay, and in these patients, you need only oral medications. You don't need IV medications. Okay, start them with a patient. If the patient is already on medications and not taking them, put them back on their medications if they are appropriate. If their medications are not appropriate, then optimize the medications. If they're still not diagnosed with hypertension, then you can start them on appropriate blood pressure medications and control the blood pressure over 1 to 2 days. You don't need to lower the blood pressure acutely, because lowering the blood pressure acutely can cause problems like strokes, acute MI, acute kidney injury. It's not something you want to do without end organ damage. In case of end organ damage, you have to stop the pathological process. So that's why you lower the blood pressure acutely. Now we come to secondary hypertension, and we're not going to talk about all the causes of secondary hypertension, just some of them, but you will encounter other causes of secondary hypertension in other lectures. Okay. So depending on the systems, okay, we have renal causes, and we'll cover it in the renal acute and chronic kidney disease lecture. We have endocrine causes. We'll talk about some of them. Okay, other causes might be covered in other lectures. Okay, we also have to focus on medications such as oral contraceptives when we take history, and NSAIDs. Okay, very commonly used medications. Okay, sympathomimetics, we find them in cough, common cold medications, and ephedrine, pseudoephedrine, decongestant medications commonly used by patients. Illicit drugs, okay, cocaine, stimulants, okay, coarctation of the aorta. You have to check the blood pressure in upper limbs and lower limbs and see the difference. Other neurological problems, sleep apnea. Okay, probably we covered in the other lecture. Okay, so those with sleep apnea, obstructive or neurological sleep apnea, both have higher blood pressure. Okay. Volume overload, usually it's iatrogenic from excess IV fluids. We see it in inpatients when we give them a lot of IV fluids. Rarely seen it from excess salt intake, okay, but volume overload mostly seen by giving them IV fluids, excess IV fluids in the hospital. Okay, so renovascular hypertension, and this type of hypertension, there's reduced perfusion to the kidneys. Okay, and this leads to the kidneys releasing renin activation of renin-angiotensin-aldosterone system, which raises the blood pressure. Okay, because the kidney has poor perfusion, and the kidney cannot differentiate between renovascular disease or true hypovolemia, so it responds by increasing or activating this system, the RAS system, which causes sodium and volume retention. Okay. We have two major causes of renovascular hypertension: atherosclerosis and fibromuscular dysplasia. Okay. In atherosclerotic renovascular disease, usually we see it in those above 50. Usually they have other systemic atherosclerosis like coronary artery disease, strokes. Okay. Fibromuscular dysplasia, mostly seen in young females less than 30 years. Okay. Investigations, you can use CT angiogram or a contrast angiogram in a cath lab. You can do a captoprenogram or magnetic resonance angiogram. They all help us check the renal arteries, okay, or the blood flow in the renal arteries. Okay. So you have mostly two scenarios. Okay. Either you have unilateral renovascular disease or atherosclerosis. Okay, unilateral. Okay, one is normal and the other one is has atherosclerosis in the renal artery. Okay, or you might have bilateral or single kidney with renovascular disease. And bilateral or single kidney with renovascular disease, they have the same pathophysiology. Okay, so if you have unilateral, the affected kidney will activate the RAS system and cause sodium and water retention. Okay. And in case of the bilateral or single kidney with renovascular disease, there's activation of the RAS system. Okay, and there's low GFR. Okay, so there's low the filtration and elimination of sodium is less in the bilateral or single kidney with renovascular disease. And in both cases, that you'll end up with high blood pressure. Okay. So treatment, we always try medical treatment. Although the renal artery is affected, okay, for those with we always first use the medical treatment. Okay, so they have activated the RAS system, so you can use RAS blockade medication, ACE inhibitors or ARBs. Plus, you can use calcium channel blockers or diuretics. Okay, but some of them, if you give them RAS blockade, they develop renal impairment, and you're required to stop the medication. Okay, so you have to monitor renal function after you start RAS blockade. Okay, medications, ACE inhibitors or ARBs. Okay. Now, renal revascularization, either by angioplasty or stenting or surgical intervention, we only use this. We only use these procedures if the patient is not responding to the medications. 1, 2, the patient is developing adverse effects from medications like renal failure or hyperkalemia. Okay. 3, if they have flash pulmonary edema. Okay, these patients with renovascular disease, they can develop sudden acute pulmonary edema. We call it flash pulmonary edema. In this case, these patients require one of these procedures. Usually it's angioplasty plus minus stenting, okay? Now we're going to talk about primary hyperaldosteronism, okay? Where there's increased release of aldosterone, okay? It can be caused by either adenoma or hyperplasia of the zona glomerulosa of the adrenals, okay? And usually they have the clinical scenario is resistant hypertension, okay? You give them hypertensive medications and they're not responding. 3 medications, one of them diuretic, still high blood pressure, okay? Hypokalemia as a direct effect for aldosterone effect can be present, but not necessarily, okay? You can have normal kalemic patients with hyperaldosteronism, primary hyperaldosteronism, but it's something to look for when you look at the labs, okay? But absence of hypokalemia does not rule out primary hyperaldosteronism, okay? So if you have a resistant hypertension in a patient, one of the causes could be primary hyperaldosteronism. Diagnosis, we usually use the first test as a screening test, aldosterone-renin ratio. Okay, if it's more than 25, it highly suggests this disease, primary hyperaldosteronism. In this case, we proceed with imaging studies like adrenal CT scan. We also use one of these studies, oral sodium chloride or saline infusion or chlorocortisone or captopril. All of these interventions lower the aldosterone. Okay, you increase the sodium load or a hormone that should suppress the aldosterone. So all of these interventions suppress aldosterone. Okay, so if you attempt to suppress aldosterone and you check the aldosterone pre and post intervention and you find that it's still high, this suggests that there's uncontrolled release of aldosterone and primary hyperaldosteronism. In normal people, if you use one of these interventions, the aldosterone hormone level will go down after using one of these interventions. Okay. Okay. So treatment, if you have an adenoma, then surgically removing it will solve the problem. Okay, other than that, you need a mineralocorticoid antagonist if the patient is not a good surgical candidate or if it's bilateral, okay? So you can use spironolactone or liprinone or one of the newer mineralocorticoid antagonists. Okay. Cushing syndrome, in this case, you have excess glucocorticoid, sustained excess glucocorticoid hormone. Okay, it could be from an ACTH producing pituitary adenoma, overproduction from the adrenals from an adenoma or a carcinoma, or ectopic production of ACTH secretion, like we see in some type of cancers, like lung cancer, ectopic production from a lung cancer mass in the lungs. Okay. They have typical features of Cushing syndrome: central obesity, striae, buffalo hump, plethoric faces. On labs, you'll see that they have insulin resistance, okay, high blood pressure. Okay. Diagnosis, you can check for urine-free cortisol. Check that. You can start with this as a screening test, urine-free cortisol level. And it's a 24-hour collection as a screening test. Okay, if it's high, then you can proceed with the dexamethasone suppression test. We have 2 types, high dose and low dose dexamethasone suppression test. The low dose dexamethasone suppression test, you give the dexamethasone and check the cortisol level before and after. If it's suppressed, then you have Cushing syndrome. Okay. The high dose differentiates between you check the ACTH level. Okay. The high dose dexamethasone suppression test differentiates between ectopic ACTH secretion and non-ectopic ACTH secretion. If you have ectopic production of ACTH, it will only respond, the ACTH level will be suppressed only with a high dose of dexamethasone suppression test. Okay. So treatment, if it's a pituitary adenoma, then it should be surgically removed. Okay, if it's in the adrenal problem and unilateral, you can do unilateral adrenalectomy, okay, which will solve the problem. Okay, Pheochromcytoma. These are patients with continuous or episodic production of catecholamines, okay. The source of these catecholamines could be from the adrenals. It still can be like in 10% extra-adrenal, okay. It also can be from malignancy in 10% of cases, okay. Usually they have episodes of headaches, palpitations, and anxiety. Like it comes in bouts, attacks, okay. So if you have this typical clinical scenario and somebody with high blood pressure, you should think of pheochromocytoma. How to diagnose it? You can check plasma metanephrines. Metanephrines are the metabolites of catecholamines. Okay. You can check also urine catecholamines or metabolites. Okay. You can do a clonidine suppression test. You can do an MIBG scan. It will tell you the location of the abnormally secreting masses, either adrenals or extra-adrenals, releasing catecholamines. Okay, you can do imaging of the abdomen, either MRI or CT, looking for abnormal masses in the abdomen or pelvis. Okay. Treatment: if the adrenals appear to be large and malignant appearing, okay, then surgically removed. Okay, especially if the size is more than 4 centimeters. Okay, you also should check for MEN2 disease in the patient and probably in the family. Okay, if you multiple indifferent neoplasia type 2, okay, because it comes with different other pathologies like hyperthyroidism, thyroid cancer, okay. So the patient and probably the other family members for MEN2 disease screening, assessment and screening. Acromegaly. Acromegaly is excessive circulating growth hormone, okay, from the pituitary, from a pituitary adenoma, okay. They have the typical features like they have coarse enlarged facial features, okay, large skull, large hands, large feet, okay. They might even have like neurological problems from pressure on the nerves coming out of the skull, like cranial nerves coming out from the skull, causing pressure on them. They might have symptoms related to this pressure. Diagnosis: you're supposed to check for serum growth hormone. Also, you should do a glucose tolerance test, okay, and MRI of the pituitary gland, okay, to confirm the diagnosis of acromegaly. Treatment: if it's an adenoma in the pituitary, it should be removed surgically. Or if the patient is not a good candidate, or you can use medications that can control the growth hormone secretion, like dopaminergic agents, bromocriptine and cabergoline, which inhibits the pituitary gland. Or we can use the somatostatin analogs, okay, like octreotide. Okay. Pathophysiology of hypertension and acromegaly is probably multifactorial, okay. There's increased aldosterone secretion causing more sodium and water retention. There's also insulin resistance also causes increased vascular hypertrophy and increased resistance, okay, causing increased vascular resistance. They also have increased sympathetic activity. So multifactorial, all ending up with high blood pressure. Hypothyroidism, low thyroid function, okay. So hypo and hyper both cause hypertension. And in the hypothyroidism, there's deficient production of thyroid hormone. It could be from inadequate TSH secretion because of pituitary or hypothalamic problems, or it's in the thyroid itself, okay, a problem in the thyroid itself, like autoimmune disease, iodine deficiency, etc. Okay. So in these patients, the pathogenesis is multifactorial, but they have increased total body sodium, okay, and increased peripheral resistance, okay. How to diagnose them? You need a thyroid function test and treatment, and you might need other tests to find out exactly what's the cause of the hypothyroidism. I believe it's covered in other lectures. Treatment: You need to replace the thyroid hormone, thyroid replacement therapy. Hyperthyroidism, increased activity in the thyroid gland. Okay, you can see it in Graves' disease, toxic multinodal goiter, toxic adenoma. Okay, all have increased secretion of thyroid hormones. Okay, uh, it's associated with systolic blood pressure. Typically has systolic blood pressure and normal or low diastolic blood pressure. And again, diagnosis to find out, like just a screening test, thyroid function test, and you'll need additional tests to find out exactly what type of hyperthyroidism you have, and also it's covered by in another lecture. The treatment, you need antithyroid drugs or surgery to remove the thyroid gland or radioiodine, okay, ablation. To control the symptoms until you treat or you do the definitive treatment, you need beta blockers. Okay, so beta blockers, especially propranolol, non-selective, uh, is probably the best drug to give in hyperthyroidism patients with symptoms until you treat the cause of their hyperthyroidism. Beta blockers. So a general approach for a hypertensive patient, you definitely need to take a history and do a physical examination. History, and remember the most common clinical scenario for a hypertensive patient is asymptomatic. Most patients are asymptomatic. They might have a blood pressure of 200 and walking on the street, no symptoms. Okay, so hypertension needs to be screened for. Okay, like a wellness check at least once a year in normotensive people. Okay, so they don't expect to have symptoms from hypertension. If you have symptoms of hypertension, then it's either a complication of hypertension, like coronary artery disease, stroke, renal failure. It's a late stage, okay? Or you have end organ damage in a hypertensive emergency, and it's also a late stage, okay? So most people, they don't have symptoms for hypertension, but in history, you should look for risk factors, okay? Like if they have diabetes, if they are smokers, and look for symptoms of secondary causes, okay? Like if you suspect secondary cause, you should ask about those symptoms of secondary hypertension, like the diseases that we just discussed, okay? Okay. Labs, we only do general labs, like initially, like kidney function, electrolytes, because renal failure can cause high blood pressure, chronic disease, and high blood pressure can cause chronic kidney disease. Also, we check for calcium. Hypercalcemia can cause hypertension. And if you have hypercalcemia, you have to find out the cause of hypercalcemia. Is it hyperparathyroidism? Is it granulomatous disease? There's many diseases that cause hypercalcemia. We need to check a CBC. Polycythemia can cause hypertension from hyperviscosity syndrome. Okay. Fasting blood sugar, because diabetes is a major risk factor and cardiovascular risk factor. Lipids, dyslipidemia also as well. Thyroid function test looking for hypo and hyperthyroidism. Urine analysis to there's renal damage or renal problems. Just X-ray in some patients. Okay, even ECG and echo in some patients. Renal ultrasound also in some patients. Okay. But we don't do all the lab tests that we just mentioned for secondary diseases. Okay, so you do the basic test. Okay, if you don't find any clues from the history, physical examination, and initial lab workup to suggest a secondary cause, then you can start the patient on appropriate medications. If it's essential hypertension, they will respond and the blood pressure will be controlled. If it's secondary and you haven't yet diagnosed the cause of high blood pressure, then the blood pressure won't be controlled with the initial medication. And this is when you start looking for secondary causes, okay? So when do you check for like secondary causes or the special tests? If you have unusual presentation, okay, not the typical age of onset of hypertension, or if you have like a high stage of hypertension, okay, abrupt onset of hypertension, in someone who is previously normal, okay? If you have drug-resistant hypertension, as we mentioned, drug-resistant hypertension, If there's a clinical clue from the history or initial workup to suggest a secondary cause, okay, such as abdominal bruit, it suggests renovascular hypertension. Low potassium, it suggests hyperaldosteronism, primary hyperaldosteronism. So this is when you look for or you order special tests, okay, for secondary hypertension. You don't order them routinely, okay. Only those who don't respond to medications, atypical presentation, or a clinical clue from the history examination or initial labs, okay, to suggest secondary hypertension. And you order only the appropriate secondary hypertension uh, test, okay. Low serum potassium, you're thinking of primary hyperaldosteronism, you do the screening test for primary hyperaldosteronism. If it's positive, then you proceed with the other investigation, because secondary hypertension workup is very expensive, okay. Okay, so this is the lecture for hypertension. اوكي. طيب، التنتين وربع، تنتين وربع بنبلش المحاضرة اللي بعديها. ماشي
ان شاء الله.
تنتين وربع، ماشي. يلا اوكي.